start. Today we'll be studying the entire chest radiograph. All the way, all the views in depth, so that this would be like a bridge between respiratory system and the cardiology. So all ins and outs, all the details. Study. I don't know why there are just 33 people. That's sweet. Yes, yes. So let's start with something. So being an MBBS student, you are expected to know reasonably well in radiology. So one is the plain radiograph. When we say radiograph, radiograph means nothing but X-ray. So truly speaking, X-rays, so they are the specific X-rays, specific rays which are into the electromagnetic spectrum. And these are the X-rays which can really penetrate into the body. And depending upon the density, radiology means, I mean, grossly you can say X-ray, but that's why I'm explaining this. That is not only the X-ray. It is not so. Gone are the days when we were telling that radiology means X-ray. So this is one, that these are the X-rays which are part of electromagnetic spectrum, right? And because they pass through the body, and then they expose the radiographic plate, right? Now this plate is sensitive to light. So when these lights, when the rays fall on it, right? When the rays fall on, let's say rays are falling on this surface. So when you develop this, so silver nitride from this particular surface, that will be washed off, right? That would be washed off. It will go away, and that area would appear white. Right? So this is when we are developing it. But when the X-ray, it is fixed. I mean, when it comes into your hand, so you will find that these are the bones, right? The bones, they look white, right? The bones, they look white, because when we sit, have you seen the negative image? Way back, but when the photographs are there, so there is a negative image, right? There was a negative. In older days, there was negative. So when the white was black and black was white, right? So that's how it is there. And then when the X-rays are developed, now instead of these X-ray plates, now there are the receptors. They are coupled, they are the couplers receptors. So these receptors, these electronic devices, they are the photosensitive receptors, and then they develop the image. So that is in the form of digital. But just do remember that whenever you see on X-ray, whenever we see white, that means X-rays, they were unable to penetrate. Right? And whenever you see black, so that means X-rays penetrated fully. Right? They passed through and through the body, and then they exposed that way. X-rays penetrated fully. So that's how things they really go. So this is plain radiograph or the plain X-ray. Then came the angiography. So in angiography, you are injecting a dye, right? And this dye is iodine based. Now, because iodine is radio opaque, right? When we say radio opaque, anything whenever we say that it's radio opaque, that means X-rays, they cannot pass through it. X-rays cannot pass through it. So normally when you try to take X-ray, do you see the arteries? No, you don't see the arteries. Right? You just cannot see because it is a very soft tissue. The X-rays will be passing through and through. But when there is a radio opaque dye, that is when we inject the dye, let's say it is injected into the carotid, as it is going into the carotid, and then you take the X-ray. X-rays, they won't be able to pass through this iodine. But because this iodine based dye, it is into the carotid, they will be able to see the structure of the carotid. This is the basic principle. Whenever you will be taking, say for example, you give the patient barium, right? Barium is also radio. Barium which is used, right? Barium which is used for GIT. So you want to detect whether there is any, let's say, esophageal constriction is there, or is there any ulcer into the stomach, or is there any duodenal atresia, right, in which the duodenum is narrowed down. So the dye, instead of this barium, is to be given in large amount. Right? There is barium swallow, so in which there is 1 glass of barium, patient has to drink and immediately take that. So you'll be able to see the entire esophagus. So these are all radio opaque substance. You cannot see the soft tissue, but because you can see these substance, they will be giving you the shape of that particular organ, and then accordingly you diagnose. This is right. Still there are angiography, there is intravenous pyrography, that means you inject, and when it is passing through the kidneys, right? When the dye is getting filtered through the kidneys, at that time you start taking that, so that you see the complete kidney architecture. Right? And when the dye is passing through the ureters, so when you take the X-ray, you'll be able to see the ureter. So it means that if these are the kidneys, you'll be able to see major calluses, minor calluses, everything. Right? And as they will be passing through the ureter, you'll be able to see even the ureter. Now, let's say if there is any stricture or if there is any stone, you'll be able to see that. You'll be able to see, is there any hydronephrosis, that means is the kidney enlarged? Yes, you'll be able to see that. So much so that when this is the bladder, right, over here, then this is called as the cystogram. Cysto means the bladder, right? Gram means you are watching it. So you watch the bladder. Similarly, you can tell the patient to pass the urine, and at that point you take the X-ray. Right? It is called as the micturogram. So when patient is micturating, the patient is passing urine. So then you see that is there any narrowing. So this is all we'll study when we'll be studying the abdomen, right? When we'll see whether the urethra is okay. Because in case of males, say just at the base of urethra, there is a gland which is called as the prostate gland. Now, whenever there is BEP, benign enlargement of prostate, right? Or it is also called as benign prostatic hyperplasia, right? They both are seen. So when the prostate is enlarged, it will compress the ureter, and you will find that those persons, they won't be able to pass the urine very smoothly. Right? This is pretty common in case of males. So that's why for all these things there are special procedures, but the basic principle remains the same. that whatever the substance which is used, it is a radio opaque substance, and when it is passing through that particular organ, you really see the architecture of that. So same principle, you want to do the carotid angiography. So yes, carotid, then external and internal. Intercarotid will go into the brain, and then you see the complete cerebral angiography. Right? You see the structure of the brain, that where exactly the blood supply is going. Similarly, you go for coronary angiography. So then the whole thing all the way, right, will be passing what is called as the headhunter catheter. That will pass into the femoral, from the femoral it will go to the aorta, all the way reverse, then it will go into the arch of aorta, you reach it to the base, and then the dye is injected, and immediately you see this. We'll see all these procedures. Actually, we'll see all these procedures. I'll show you some of the videos also of my patients. So, and trust me, it is like after 1 hour, you will be able to diagnose, pinpoint, you'll be able to diagnose that whether this is a normal angiography or if there is a stricture. If there is a stricture, so it is in which artery, it will be affecting which chamber, what would be the sign symptoms, all those things they can be understood, right? And yes, in the first year, right, I got some of the negative comments also, but I'm not talking about. Some of the very negative hate mails have come once again they have started. But don't worry about it. I know what I'm doing. And yes, say in first MBBS, right, I don't know whether that person is here or not. Those persons are here or not. But yes, by the end of first MBBS, you will be able to diagnose the ECG effectively. You'll be able to diagnose the X-rays very effectively. CT scan, definitely yes. MRI, I'm writing this thing so that because this will be saved and it will be recorded, right? So yes, you will be able to understand all these things. And yes, definitely the coronary injury. In very harsh words, the knowledge is a baap ka nahi. And it's not so that you have to be 2 years or 3 years senior and then learn ECG, learn the basic principles, and I'll give you not less than 50 ECGs for practice. And that's right, Rishikesh. I totally agree that these things, they come in final MBBS. But you know, final MBBS mein kya hota hai? In final MBBS, when you are into the term of medicine, right, irrespective of the college, kitni bhi achhi college ho na, straight away yaar clinics mein X-ray dete hain, diagnose. यार मतलब how? जिंदगी में कभी पढ़ा ही नहीं था, पता ही नहीं था. We used to avoid कि जाने दो, अभी एक्सरे बाद में देखेंगे, सीजी बाद में. The basic things are known. This is P, this is Q. The sir used to beat on the head. Final में आया, and what is this PQRS diagnosis? And then we were fumbling. I mean, what really happens is, let's see, if I'm teaching you driving, I tell you, beta, this is accelerator, right? So this is brake, this is clutch, and then there are 1, 2, 3, 4, 5 gears, and there is a reverse gear, right? And this is the steering wheel. Samne dekho and start driving. Right? Driving to itna hi hai na. Right? Actually, if you are driving a car, it is only this much. But when you learn it, you know that there are so many things. Exactly the same way, one thing, what is pure theory. I'll first teach you in one day, I'll teach you the theory part. Today only, right? You'll see that first initial half an hour would be the theory part. And then straight away we'll go for the practical. That what exactly to do, right? It will open up the completely different perspective. And then we'll be going for, later on, we'll be going for CT scan and the MRI. Because my dissertation was on MRI. So in MRI, actually, I'll show you my dissertation also. In just 2 pages, there are some basic principles. And if you remember that, you'll be able to see immediately and you'll be able to tell that yes, there is a desiccation of intervertebral disc at this junction, and which is compressing the spinal cord, right? And what will be the symptoms? You'll be able to see it within seconds. So I totally agree. These are the topics of final MBBS, but there is no harm. So I think it's time now. Now we can really start. So those who have joined a bit late, welcome. And here is our first position. Our topic for today is X-ray chest. We'll be focusing only on X-ray chest. Now this particular PDF, you need to remember. Yes, you need to remember every word of it. Right? I have prepared this, though this was prepared for the USMLE. But that's why don't miss even one single word. Anything, if you don't understand, let me know instantly. Alright. So here it is. We are starting with PA view, postero-anterior view. Postero-anterior view, that means X-ray will be passing from the back side and they'll be coming from the anterior side. So PA view. Most common, absolutely most common. The direction of X-ray beam is from posterior to anterior. Clearly samajh aaya. X-ray beam is centered. Now this is important. This is what is called as the centering. Centering means what? When the patient is standing, right, when you on the back side, right, the patient is over here. Here is the X-ray plate. Patient's nose is towards that. So this is the posterior side. X-ray beam, it will be entering from here, right? It will be striking the X-ray plate. But here is the X-ray beam's machine, right? So the X-ray will be coming out of this. So there is a light, right? When you switch on that light, so it will be giving you the cross mark. Right? So you can really center, because X-rays, so you can't see. So then how will you know that X-ray will be passing exactly into the center of the chest? Kahin upar hua, niche hua. So it is exactly like aankh band karke photo liya, then sir aadha kata hua aaya, right? Sir aaya hi nahi, right? All those things, they can happen. But because we can see, right? So then we know that yes, I am composing the photograph very properly. Right? So over here, because you cannot see the X-rays, that's why there is something what is called as the centering. This centering will be there in all the X-rays, in any of the angle, so that when you switch on the light, right, to a crossbar will, it is exactly like sniper gun, right? Sniper, right? Sniper ke andar, where the bullet would go, there is a dot, red dot. Right? Movies mein dekha hoga, red dot, right? So that is the X-ray beam is centered at inferior angle of scapula. So here it is on the back side. This is one scapula. This is second scapula. Right? So you draw a line over here, and this is the center. This is the point. This is the point. Right? So that is the inferior angle of scapula. Right? Inferior angle. This is called as the inferior angle. So in scapula there are three angles. One is the medial angle, lateral angle, and the inferior angle. Right? This lateral angle, that is where the humerus will be connected, right? Okay. So that's where the inferior angle, and this is the center. So that is what is called as the center. This particular thing, sometimes, say, when you take the X-ray, so this is the level. It is the T7 spinous process or T8 body. Vertebrae, they are arranged like this. This is the T8, thoracic 8. Then there would be intervertebral disc. Iske upar aaya T7, right? Below there would be T9. But in the vertebra, the posterior end, right? The posterior end, that is called as the spine. So that spine, it goes like this. It goes like this. It goes like this. So when we take the level, right? When we take the level of this level, so it is body of T8 vertebra or the T7 spinous process. This is the spinous process of T7, because the spinous process is coming from the top, right? Spinous process is coming from the top in the T8 body. So T8 body or the spinous process, it is the level of the inferior angle of scapula. This is one of the questions, right? Many times in exam they ask you this question, because this is very specific. And in this, if they say it is the body of T8, T9, T10, right, T7, so only one is the correct answer. That's why you need to know. There would be several questions from this. Right? And once you study, this is just 12, 13 pages of PDF, but it is comprising of not less than 30 questions. Right? Intervertebral disc. It is the body. Very specific things are there. Remember. So it is the body. See, this is the vertebra, right? This is the T7, then T8, then T9, right? Thoracic vertebra we are talking about. This is the side view. So in side view, the posteriorly, right? These are the spinous processes. They are called as the spinous processes, right? Vertebra, they have got the transverse process, right? Transverse process. So if you watch the vertebra from the top, right, ऊपर से देखो तो then vertebra would be looking like this, right? And this is the spinous process. This is the top view. So here, this is called as the transverse process. Transverse process. This is the body, right? And this one is the spinous process. Spinous. This is anterior. This is posterior. And to write it in more detail, then there is a pedicle. And it is in between over here, there is the spinal cord, right? The spinal cord will be there. Correct? So that's how the vertebra is there. So this is the spinous process. So when I draw it like this, the T8 body, so this is the level of where you have done the centering. So when you do the centering, so it is between, and see clavicles, so when you tell the patient, you just keep the hands like this, right? The hands are to be kept like this. So that scapulas, they go out of the lung field. Right? Scapulas, they go out of the lung field. So you'll be able to see the scapula. When you had told the patient, right, you'll be able to see the scapula very clearly, lower end. And if it is not seen, then you can even palpate. It's very easy. Even if you try to do. And right now, why are you looking at the clavicle? Don't jump on it. I have not even told you to see this X-ray at this point. So don't jump. So we are talking about T8. So when you do the centering, so that centering line is passing through T8. Importance of this we'll just see. Right? So here it is. It is either T1 or the spinous process. This is the spinous process. This is the spinous process of T7 by 2%. Okay. Here it is. It can be low KVP. No one would ask this question because all these are from post-graduation purpose, but still you need to know. It is as such very simple. If you are into photography, right? If the light is less, what will you do? The shutter speed, that will be, exposure time will be more. Correct? If you have done the photography, if the light is, raat ko photo lena ho, so then you press that, take the photo. Now in cameras it is automatic, but otherwise in those SLR, single lens reflector, it is called as SLR cameras, right? Manual cameras, not flash. Don't confuse it, right? If you want to take the photograph of sky, right, that is stars, when you be using the flash, must, right? Flash Mario will star ke pigiri, and then you can take the photograph of star. No, what you do is, it is called as the exposure time. Exposure time means what? See, this is like the shutter which is closed. Shutter opens, so light starts entering, and then you close it. If you are taking photograph into bright sunlight, then photograph will be taken in a flash, satak, right? Ekdam fast, in a second, in a milliseconds, because there is enough light to expose the exposure plate, right? That click of that camera, right? That click of camera, cutter, right? That sound, that is the shutter opens and then it closes. But if you try to take it in night, so then there is a beam on. So you press, and then you are allowing the light to go in. I'll show you some of my photographs which we took it for the fireworks, right? In fireworks, if you straight away take the photograph, there is no fun, right? It will be like a free section. But when you take it, you connect the camera, put it on stand, you connect your remote control with it, and then make it a B mode. And then as soon as that rocket goes up, you press the B button. So now it is starting, it is picking up the light and the plate is getting exposed. And then you shut it down. So you will see that stream of light and then all the beauty of those colors. Right? This is what is called as the exposure time. Exposure time. And how much shutter would open and how much shutter would close. Right? That is also a timer mechanism. That is also which governs. Finally, good photography is what how much light you will permit so that you get the best what you really want to see. Right? Whether it is at a longer distance, whether it is at a shorter distance. In radiography, it is like basically photography. So when we'll be studying this thing in more detail, right, there is a complete physics, complete optics which is related to the photography. We'll learn that because it will open suddenly a completely new vision that this is how it is happening. Over here, we need to involve some of the physics also. This is what is called as the KVP, kilovolt potential. Kilovolt potential means that is when the X-ray beam is there, how powerful the X-ray beam is. Will it be powerful and it will go through and through, or it will be weaker one? Right? You have to visualize a bit because these two sentences will teach you so much equivalent to a radiologist. Think it like that. We want to see small structures, right? We want to see small structures. Take it this way, that here is the X-ray plate, and then there are some structures, right? I'm drawing it. Let's say this is 1, this is 2, this is 3. X-ray beam goes from here. If the X-ray beam is strong, right, so it will dark, it will go through all of them. If it is passing through all the 3 structures, will it be casting any shadow over here? It won't, right? It won't. If the X-ray beam is passing through and through all the 3 structures, it won't show anything. Cricket match देखिए. In cricket match, the players के कोई shadow नहीं होता because from all the sides, right, they have put the light. So there is no difference, right? Wherever the shadow is, that light means it is illuminating. So that's why you won't find any of the shadow. But if there is only one light, then immediately that shadow will be there, right? So here, now what if I decrease the strength? I decrease the strength. Kaise? I'll tell you. But I decrease the strength and I decrease the strength in such a way that it won't be able to pass through 3, but it will be able to pass through 2, it will be able to pass through 1. So now what would it really happen? On screen, will I be able to see the shadow of 3? Correct? But I won't be able to see the shadow of 1 and 2 because still the beam is so powerful, it is going through 1 and 2 and it is illuminating, so we are not watching it. Correct? Is this clear? Right. Just keep letting me. Because it happens like after some time, suddenly you say, can you please repeat? Right? So instead of that, because there is lots and lots to learn today. So if there is any doubt, just tell me at that point. एक बार आगे बढ़े तो then we don't have to go back. We decrease the intensity still. Power of this beam. So now this beam cannot pass through 3. It cannot pass through 2, but it can still pass through 1. So now we'll be getting the shadow of 2 and shadow of 3. Correct? And we decrease the strength still more so that it cannot pass through even 1. So now we'll be able to see the shadow of 1 also. So that's the point. That is called as the KVP, kilovolt potential. That is when the current, how much current it is used. Exactly. So lower the KVP, right? Lower the KVP, that means low penetration. This is called as low penetration. And when there is low penetration, there is high contrast. High contrast means even if they are overlapping, doesn't matter. Yeah, that is called as the silhouette. That is called as the silhouette. We are just coming to that. Right? Even I'll show you that also. So when the shadows are overlapping, we'll come to that. Just hang on for a minute. But over here, this is the principle. Low KV, that means low penetration, that means high contrast. High contrast means the ability to differentiate the surrounding structure. That is called as the high contrast. So whenever there is any calcification, miliary shadows, right? Then in tuberculosis, there is miliary tuberculosis, right? We'll see all those X-rays when we'll be discussing those pathologies, but miliary shadows mean . If the beam is powerful, whitewash, right? मतलब पूरा black ही दिखेगा. You won't be able to differentiate between those delicate shadows because these are all delicate structures, very small structures. So that's where we decrease the KV, right? So the penetration is less, won't be able to penetrate through and through. So that's why it would be stopped by all these chote structures. There is small calcification, it will stop. There is a dot miliary, it will stop. So that whenever the X-rays are stopped, that means on the plate, they will really show their shadow. And X-ray is nothing but game of shadows. When do you want to see the high? When will you use the high KV? This is for hidden areas of lung field. Right? There are some hidden areas of lung field. So this is pure for post-graduation. But hidden areas of lungs means those lung fields which are normally not seen. Why? Because they are obscured by the other tissues. So over here, high penetration, so our beams, they really pass through all those normal areas, but they won't be able to pass through those hidden areas because their densities are different. So that's where you'll be able to see, there is some tumor or there is some tissue or there is some damage. I'll show you even such X-rays. But in most of the cases, you use this. So this is so good, low KV, so every time you use the low KV only, it looks like so good, kitne maje, right? That always will use the low KV. And you use low KV, now you have to become a physicist. Now you have to think from the perspective of when the beam is passing through the body, it is not damaging the body. But when it is stopped by the cells of the body, so these radiations, they pass through the cell and they start affecting the amount of water into the cell. And that is what leads to radiological damage. Right? Mutation, not necessary. Mutation is at a later stage. Right? Itni fast mutation nahi. Mutation will take more time. But the cellular death can occur. If it is minor cellular death, doesn't matter. It doesn't matter. So, aram se, comfortably, you take the X-ray and it won't matter. When it really matters, it matters in case of female. In case of female, right, when you know that female is in her fertile age, right, when a female is in the range from 20 to, let's say, 40. So sometimes we take the history, whether the female is married, unmarried. Female is married. We ask about her LMP, last menstrual period, before how many days. Now let's say that female has come exactly on the 14th day. We deny. Right? It is said very clearly that today we can't take your eggs. Reason? This is the day of fertilization. Right? The ovulation has occurred. Now that ovum which has released, and in case if she conceives, the chances of congenital heart defect they increase. Because it is possible that this much radiation also might have damaged the ovum. That can lead to problem. Or it is clearly said that don't be pregnant in this cycle. Wait for a few days and plan next month. Or the radiograph is not taken, especially any test before doing that. There is no test. No test. Right? This is a very common sense, right? Common history. People laugh. People laugh. being a radiologist, ऐसा कैसा question? But this is the reason behind it is that why are you asking about the last menstrual period? It is for this particular purpose, because unknowingly, if you have taken the X-ray, you are not asked for it, and in case एक X-ray ठीक नहीं था, you took second X-ray, you took third X-ray, right? There might be some pathology. So you took the lateral X-ray, 3-4 X-ray ले लिए. And what if that one which was released, right, which was released from her ovaries, and that thing is damaged? Now, if that is damaged, if she conceives, right, and if it is fertilized, what would happen? That baby, right, that baby would be liability for that couple for whole life. Right? One simple mistake. Neither you nor anyone would know into the world that this happened because of this particular. So that's what is called as the responsibility. Now, and who knows? Once you know this thing, these are, say, in medical, there are some aha factors. Right? This is one of that. That yes, and as soon as you or any one of your relative, right, or you are into clinics, and the moment you will see that she is young, let's ask before going for the X-ray. Right? Now let's say, what about female radiologist? What about female radiologist when they are there? So whether female or male, say if you are exposing so much of radiation on yourself, so that will lead to permanent damage. This is the reason that, like Maharana Pratap, right, जो बख्तर पहनते थे, exactly like that, a thick lead gown is worn. Thick lead gown and the goggles. All those goggles, they won't allow any penetration of the X-rays, and those thick gown won't allow any penetration of the X-rays. हाँ. Pregnant से क्या X-ray निकले तो baby को X-ray हाँ. Definitely. I was just coming to that, but so I'm good that you asked this question. Right? So that's why I'm taking it right now. For pregnant female, right? For pregnant female, whether it is first trimester means first 3 months. Fully capital no X-rays under any circumstances. कुछ भी नहीं. Never X-ray. Right? Go for ultrasound, go for any of the other things, but X-ray, no way. Second trimester, third trimester, depends. But again, when the organ formation stages, it's totally contraindicated. When we say contraindicated, means it is simply no. X-rays are not taken. Good question. Right? Definitely not. Right? You can go for ultrasound, USG. USG is safe. USG abdomen and pelvis. That is totally safe. CT scan, big no. Because CT scan is what's using X-rays. MRI, no worries. MRI can be done. Right? So all these are part of radiology. So this is where the X-rays were used. Then the USG, right? Ultrasonography, when the sound waves are used. Right? In ultrasonography, it is the sound waves. I'll teach you the ultrasound also. CT scan, pure X-rays. So that's why not used. Then the MRI, magnetic resonance imaging, very safe because you are using magnetic waves. So they are in the range of Tesla. That's I think 1.5 Tesla strength of magnetism, and then it is stopped, and then those sensors, they will pick up the release of the energy, gamma sensors, and then you convert it by Fourier analysis. You convert it into image, and then you analyze it. Right? We'll discuss all these things. So this is clear. Now here is our first X-ray coming up. This is a completely normal, full, good X-ray, absolutely properly exposed. So things which you can instantly say that this is the trachea is the center, right? The heart is completely beautiful, absolutely fine, fully normal, complete heart, no worries, right? This is aortic knuckle, very nicely seen the diaphragms, right? Diaphragms. This angle is between heart and diaphragm, so that's why we'll be calling it cardiophrenic. Phrenic means diaphragm. So cardiophrenic angle. So obviously this would be the right cardiophrenic angle and this one would be the left cardiophrenic angle. Over here, these angles. This is the angle between the costal vertebra and the diaphragm. So that's why it is called as the costophrenic angle. So whenever normally when it is said that CP angle, right? So CP stands for cardiophrenic also and costophrenic also, both. But no, when we say CP angle, it would be the costophrenic. The importance of costophrenic is much higher as compared to cardiophrenic, because whenever there is any fluid collection over here, and it is much common whenever there is fluid collection, so that is called as the pleural effusion, the collection of fluid into the pleural space, right? That is far more common as compared to the angles which are when these angles are getting operated. Right? So CP angle, it would be costophrenic angle, right and left, right, on both the sides. This is about left and this one is the right CP angle. Fine. The gas which you are watching over here, you know that. I need not say this is the gastric gas, gastric bubble, because that's where the stomach would be there. Correct? And all the ribs, clavicle, right? These are the clavicles, right? Very nicely seen clavicles. And one thing you must have noticed, scapula is not seen, yeah, because when you are doing like this, right, when you are doing like this and the x-rays are coming, so scapulas, they go out of the lung field, right? Just keep this thing in mind as we'll be discussing some more important things, right? So here it is, so that's what we see. Let's move further. This is AP angle, right? And don't worry about this, that isme se kuch chhoot gaya. So many x-rays will be done. So step by step we are learning. AP angle. We have talked about it. AP view. Antero-posterior. Aage se piche. And you know it very well. Just asking this question. Why PA view and we are not taking routinely AP view? Right? PA view kyun? We have discussed this thing way back. By the way, we are almost 100 friends together. The chat is open for everyone. So there are only, I can count on fingertips, but 5 or 6 students only they are answering. So do take part. Do take part. Do write. Your name, I don't know your name because you have written it's me. That's right. AP view is for people who are unable to stand. That's right. That's very true. In PAV, the image on the screen appears sharp and less magnified. Very good idea. That's the question. That's the answer which I was asking. That whenever you look at any of the X-ray, you want that things should be sharp and things should be less magnified. So we took that when the object is over here and from here we put the light. When the light is going, so if the object is far, so then this object will be bigger, right? And bigger and it will be blurred. No, we want sharp, right? So that even if there is a small calcification, we should be able to see it more clearly. And the area of interest, that is the heart and the lungs, they are into the anterior side more. So that's why we would like to keep the plate in front. Image appears bigger, those image should appear of the same size. If it is far, so then image would appear. Maybe because you are talking about this, right? So if the object is far, the image would be magnified. We don't want magnification. We want it as near as possible so that we get the real heart size. Okay. Yes, this is for critically ill patients because they are unable to stand. Right? So they are into ICU, they are lying. Then you just push the X-ray plate underneath and then with the portable machine, you just fire, then you take the X-ray, right? So that is the portable X-ray unit. It's a smaller unit, so that's why even the quality of the image that will also be affected. But because it is portable, so at least it serves the purpose. The direction of beam, not moved, right? It is anterior to posterior. So here are the things, the difference, the view. When it is PA view, scapula is seen in periphery of thorax, right? Here is the scapula. Here is the scapula, right? Because see, the hands are like this, right? Hands are like this, so it is going away, right? Then when it comes to AP view, in AP view, look at the clavicles, which are already who is into the ICU. To him, to that, you will say, "Kare, हाथ ऐसे करो, वैसे करो." अरे, he is unable to breathe, है ना? So वो तो बस यूं पड़ा रहेगा, and then you take the X-ray. So that's why this is a very important thing, that the clavicles will be almost at the same level, while the clavicles, direction of the clavicles in case of PA view will be like this. One of the important findings, right? Easy, no big rocket science, easy to understand. Second, right? So that is clavicle. Project over lung fields above the apex of the lung field, right? So these are the above. Regarding the scapula part, they are seen peripherally, right? Over here, the scapula is overlapping. Now here it is not seen very clearly, but actually the line of the scapula is this, right? So it will be overlapping as such. As such, if you see when the patient is lying straight away, so the scapula, which is on the back part, it will be exposed to the lung, on the lung field. You know? This is over here, the ribs. Yeah, answer this. Answer this. In this, the question is that this is PA view. So which portion of the rib will be seen clearly? Anterior rib or the posterior? Anterior rib or the posterior rib? And rib has got two. Okay. I'm not telling you right or wrong, but yes. Yes, all of you who are wrong. Sanika, take care. Think again. I'm not talking about heart. I'm not talking about heart. Harshvardhan, those posterior and anterior, दो है. Samsung SM, think again, think again. Unnati, think again. Abiba, think again. Structure which is near to the plate, that would be in sharp focus. Up. The rib is like this, this is like a rib. This is the X-ray plate. This is the anterior end. This one is the posterior end, right? So which structure will be near to the plate? Anterior end. So that's why anterior ribs, they will be seen more clearly. Anterior, correct? And then same way, over here in AP view, beam has gone from anterior side coming out of posterior side to already, right? Plate is behind. When the plate is behind, then the spine is near, so posterior end of the ribs are near. They will be seen more clearly, right? So over here, this is the posterior rib. They are seen. You'll be able to see the marker PA and AP, but jaruri nahi hai. Haan. PA is posterior anterior, AP is anteroposterior, but when it is taken in emergency, many times marker, right? Straight away the X-ray is taken. So, nahi bhi hote markers. Many of my X-rays you will find that because they were taken in emergency, so chalta hai. So, this is as such. Technically, it should be there, but not always you find. False cardiomegaly is seen in AP view. False cardiomegaly. But at the end, what you asked is agreed. So, but what I'm telling you is that यहाँ से rib गई from posterior aspect, right? This is. See, the question which has been asked is that if the anterior aspect of the rib, right, over here, this is the sternum, right? So this particular end, this much end, so that is connected with what? That is connected with cartilage, correct? So cartilage का कोई shadow नहीं आएगा. That's why what you will be watching is, it is this area, right? This is the anterior end. That's what we see, right? And this is the posterior end. So when in PA view, right, this is anterior, this is posterior. When the X-ray beam is passing like this, so obviously this anterior end is near, that will be seen more clearly. So yes, we won't be able to see these cartilages. Right? Cartilages, if they are seen, so that means they are calcified. I've shown you one X-ray. If you remember, I've shown you one of the X-ray. Old man, right, in which the cartilages, they were calcified. So that's why you see the whole structure, right? All the ribs, right, because they are calcified. So in that case, you'll be watching that they are ending till the sternum, right? The full rib. Achha. Yeah, good. So false cardiomegaly. False cardiomegaly means cardiomegaly. Mega means big. So heart has become bigger. Calcified means calcification. When the calcium gets deposited, when the cartilage becomes like a bone, that is called as calcification. So calcium is once again radio opaque. So in cartilages, normally there is less of there is practically no calcium, very minimal calcium as compared to the bones. So when the calcium gets deposited, that is like an aging process. Or you must have seen that arthritis when it happens. So a very good bone, right, it is like this. But in case of arthritis, you find that something is happening like this. All these spicules, they are coming out. They are called as the osteophytes. So these osteophytes, they are developing because now the bone metabolism is not that fast and it is not reabsorbing and putting the bone into proper shape. You must have noticed that those who are runners, why they don't get this osteophytes, they don't get this arthritis, because when you run, when you exercise, the blood circulation is so good. Yesterday I was watching, I'll post that link also. It is called as the Hulk hands. I mean, you feel like this is what they do. The kettlebells, right? The kettlebells, they were so heavy, 30 kilogram of kettlebells, and then they lift it overhead, and then they put it back, right? Then once again they lift, they put it, and then back. Then after that, they have to just take that 47 kilogram of bag, right? 47 kilogram bag, they have to drag it on the upslope all the way up. And then they have to come back, then they have to do the cycling. And all these things when there was heavy. A very good comment. There was a live telecast. So, okay. So coming back to this heart. Mega means big heart, right? It is मतलब heart, मतलब दिल बड़ा होना वो अलग बात, but as a doctor दिल बड़ा होना, it's a bad thing. Cardiomegaly is a bad thing. So it means there is some problem, some defect. Heart becomes bigger. When we say heart has become bigger, no. Being a doctor, you should really know that which chamber has become bigger, right? Which chamber. So here it is the pulmonary artery which is moving out. If there is pulmonary stenosis, pulmonary valve has been shrunken. So this right ventricle has to work so hard that right ventricle will take up. That is right ventricular hypertrophy. So right side heart, and that also ventricle, that becomes bigger. That becomes its walls, they will become big. So there would be a different appearance. When the left ventricle will become bigger, so that would be a different thing. So this is how we need to see. Here for no reason, Here for no reason, if we measure the length, okay, this much, and immediately we know that if we take the whole length, so this is, if this is B, this is A, so definitely B is more than half of the length of A. Right? It is big as compared to this. This is B, and take the full length of A. So B is definitely smaller than half of it. Right? Same patient. Same patient. Over here, will enlargement cause failure due to overwork? Well, enlargement, it's a big topic because when we say enlargement, big chamber. All four chambers they can enlarge, but with different reason. It is mitral stenosis. So the load will be put on left atrium. So there will be the left atrial enlargement. Left atrium is situated posteriorly. So वहां से pass होता है esophagus. So it will cause the compression of esophagus. Person will be following a difficulty to swallow. Right? So that's why enlargement will take it in cardiology. So अभी वो tension मत करो. Right? Just see this. This is heart is not enlarged, but in PA view there is false cardiomegaly. So if you see that it is PA view, and if you find that heart looks like enlarged, don't comment. Don't comment. Right? Exactly. Enlargement is seen because heart up पीछे चला गया. What has happened is, this is the X-ray plate. Yeah. Here it is. Here is the X-ray plate. Heart is here. Right? So now it would be exposed like this. So obviously its image would be bigger because it is at a far distance. Right? It is behind. So wahan se that heart has become bigger. Correct? When over here the heart is near. Right? So straight away it has imposed the image that is correct size. Right? It is not smaller, but it is of correct size. That's the nose. Right? Here is the nose. This is the patient. Because heart is far from plate in AP and vice versa in PA. That's true, right? So I hope this you have understood. False cardiomegaly is seen in AP view, right? Sometimes they ask the question, but now once you have understood it, it's so easy. All right. Next, the universal convention of doing X-ray chest. Now you are into the radiology part. You are supposed to take the PA view. All right. So the PA view. Right? It is written X-ray chest, PA view advanced. Erect posture, patient can stand. Yes, tell the patient the correct. Right? So he is standing. You tell the patient suspended end inspiration. Now you have learned this much, that when you do inspiration, what happens? Air goes in, right? Air goes in. Then where that air will go? It will go into all the bronchi. Right, then it will start opening up and it will reach all the way till the alveoli. Correct? So inspiration, this is suspended end inspiration. Deep inspiration, right? And you are on the panel, you say, "Saans band," right? And patient would stop, and what you will see, because from that window, there is a lead sheet, but there is a glass window. From that you can watch. Right? If the patient is breathing unnecessarily, your plate would be wasted. Right? Plate would be wasted. So you once again say, stop, saans band. Right? So his shoulder will stop moving. And as soon as it stops, press the button, satak, right? X-ray taken. It takes not even 1 second. But you need to tell this patient very clearly. Suspended end inspiration, deep inspiration, stop, X-ray taken. So this is easy. Tube to patient distance. What distance to? So here is the X-ray plate. Patient to बिल्कुल जैसे चिपक के खड़ा है. हाँ, like photo, right? When you take the okay smile and then you take the photo, right? So over here you take सांस लो, stop, take the photo. And this is your X-ray tube. This distance is fixed, 6 feet. There is a wonderful calculation behind this, but don't worry, right? So this is 6 feet. You're done. Right. All good. Now let's go to ward Let's go to department. This is 7:30, right? अभी कोई seniors कोई आए नहीं है. We are supposed to take one X-ray. One patient came. That and patients, they usually come quite early, क्योंकि उनको पता है कि बाद में भीड़ हो जाती है. So they come quite early. And this patient, he came for fitness certificate, right? And in fitness certificate, X-ray chest is compulsory, right? So X-ray is taken. Here is the X-ray. Technician ने X-ray लिया and कहा तो साहब देखो, right? And then you watch immediately. Now from your knowledge, what is this? What do you see? Can you see the diaphragm? No. So that means, अरे wrong X-ray नहीं, सही X-ray. This is a PA view, कोई problem नहीं. What is this? What you have learned till this point of time? Can you see the diaphragm? No. Diaphragm are not seen. When the diaphragm are not seen, correct. Consolidation. So which lobes? Exactly. Lower lobe consolidation. Bilateral lower lobe consolidation. Both the sides, correct? So this is bilateral lower lobe consolidation. And so far we have learned that thing, that when the diaphragm is not seen, right? Crystal clear. Diaphragm is when diaphragms are not seen, it is the lower lobe consolidation, right? We said, Pagala, we can't give you fitness certificate, right? You have got the infection. Patient bola, I am a marathon runner, कहता होगा, right? यहाँ पे तो you have got infection. Go to the medical ward, take the treatment. Hard borders, so they are seen. Right? Hard borders, so they are quite seen clearly. Lower is not seen. So that's why the lower lobes are involved. Right? So, अपन junior लोग ने decide कर लिया that this is cardiomegaly, heart is थोड़ा लग रहा है enlargement, and bilateral lower consolidation. Diaphragms are not seen, right? मस्त पढ़े थे and लिख दिया report. Now the report is to be signed. Fitness certificate and report is to be signed by seniors. Right? अपने report लिख के बैठे. Right? At 9 बजे डिपार्टमेंट मतलब सीनियर्स आए, 9:30 बजे दिखाया तब ये लिया था एक्सरे, दिस इज द रिपोर्ट दिया. कहते ठीक है, कहते ठीक है, जाओ वापस इसका एक्सरे लेके आओ. So this time instead of technician we go, right? We take the X-ray. And the X-ray, this is the X-ray. यार 1 घंटे में इसका कंसल्टेशन चला गया. Right? Say must the diaphragms, they are seen, no consolidation, nothing, everything fine. Right? All good. This is totally normal X-ray. The reason behind it is कि वो technician ने ये बोलना भूल गया. Take deep breathe, hold it, and take the X-ray. Reason that the first X-ray was taken in expiration. This is very common. बहुत बार होता है. So whenever it comes like bilateral lower lobe consolidation, it is not that much common. Bilateral. And when it happens, and then patient सामने दिखता है, immediately you will know. You'll take the history, right? if कोई cough waff होता है, कुछ होता है, and then he tells, नहीं साहब एकदम बढ़िया, first class, right? Especially when for the fitness certificate, so this is the thing. Lungs, because they are not filled with air, right? So when you are doing expiration, right? So the entire breath is out. So obviously the alveoli will collapse. So when the alveoli would collapse, so those blood vessels, they will come near each other, right? Blood vessels will come near each other, and in the bronchi there is no air, so there would be crowding of vessels, crowding of blood vessels. Now when the blood vessels, they are there, so it is like a soft tissue, right? So it will give the appearance of this basal consolidation. See this, right? I'll just remove this thing so that you can have a complete. यहाँ पे लिखा ही हुआ है. So here it was nothing but bilateral consolidation. Bilateral crowding of the vessels. There was no consolidation. As you will see more and more, immediately ये X-ray देखने पे you will come to know that the amount of air in both these lungs is also less. Right? So you will straight away say that expiration में लिया है, take it again. But still, That thing comes by a bit of practice, but over here, right, say if you see the amount of blackness, right, the amount of opacity, what you see over here and what you see over here, this area appears more black, right, because the more air has gone in. So this is the secret. In expiration, lungs, they are not filled with air. Basal portion is least filled. Right? Basal portion is least filled because air always goes up. Simple, na? Air goes up. So there is less air into the base. जितनी भी air थोड़ी सी भी थी, तो that has gone up. When it has gone up, the upper lobes they are seen, but the lower lobes, there is crowding of vessels. And that is appearance of basal consolidation. So remember why this is so important. One of the question of ESM. So are there any conditions in which you have to you can take the X-ray in expiratory mode? Yes. This is also one of the question of ESM. When there is a pneumothorax, we have not studied the pneumothorax yet, but we just know this much, that pneumothorax is air in the thorax, air in the thorax. Itni sari to air hai, right? We are breathing so much of air. So, which thorax? Into the pleural cavity. Right? Where there is a fluid, there is no air. So, if the air goes inside, that negative pressure goes away, it would start collapsing. Next time, our topic would be pneumothorax, and then I'll show you one of the very dangerous thing of pneumothorax, what is called as the tension pneumothorax. So I'll show you how to identify, right? One simple X-ray chest, and then you see that it is tension pneumothorax. Sab kuch phek ke, right? Just push even the small pencil and you'll save the life of that patient. In one of the movie, which is on Apple TV, this was shown. It was a hijack movie. The name of the movie itself is Hijack. So what really happens during that flight when it was getting hijacked? One of the hijacker develops tension pneumothorax. So this is pneumothorax. You will take expiratory chest X-ray, because in pneumothorax, if you tell the patient do inspiration, right? When he is doing the inspiration, so you are making things worse, right? There would be still more increase in pressure, and his heart and everything would start collapsing. Right? So here, expiration. Then foreign body aspiration. Patient has swallowed something and it has gone into the lungs. Now you don't want that patient should deep say inspiration level, things will go still down, right? And it would be difficult to take. Then obstructive airways, bronchial asthma, emphysema, as patient cannot breathe. Right? So you can't force them to take deep breath, right? Because their breathing would be shallow breathing. They just can't take deep. And then diaphragmatic palsy. When the diaphragms, they are paralyzed. Right? Say for example, when there is vagus nerve injury, 10th cranial nerve. So in that case, these diaphragms, they are our main muscles for respiration. So when the diaphragms are paralyzed, so even if you tell them take deep inspiration, right, nothing would happen. They will just be lying there only. So you take the X-ray and you'll find that in case of diaphragmatic palsy, this dome of the diaphragm is lost and they become flat. I've shown you one of the X-rays also of that. Remember, right? The diaphragmatic palsy. So when there is flattening of the dome of the diaphragm, right? So this is these are the indications of expiratory chest X-ray, right? Question. Now let's make it easy. Now this image, I'll not mark, I'll mark something, right? But then I'll remove all the markings. You revise this page as many times as possible. Right? Do revise it very properly. Achha, by the way, can you read what is written over here, because it is in white. So I'm just asking. If you can read it, fine. Otherwise, I'll zoom it. I'll zoom. Now can you read it? Not visible. Achha, theek hai, koi baat nahi. Just I'll explain everything, but when I'll send you this file to you, that you will be able to. And now can you read it? Acha, acha, ठीक, ठीक. So let's start with the heart. In heart, four chambers, right? Four chambers like this. That's anterior. This one is posterior. This is right. This is left. As I showed you, that you just draw the heart, hold the heart like this. This is right side. So this is right atrium, right ventricle. Left atrium, left ventricle. Correct? So tilt it like this and rotate it. So it means this is the right ventricle which will be in front. Right? It is the right atrium which is on the right side. It is this one. This is the left atrium which is on the back side. Right? And it is the left ventricle which is on the left side. Here it is. This is the left ventricle. This is the left atrium. This is the right atrium. This is the right ventricle. So what we see in front is the right ventricle. So here it is. Now, if it is in front, we can't see it. We can watch only the silhouette. We can watch only the border. So see this border, this border, this border, this one, this one. Which one it is? Right atrium. So that is done. Right? Ye pakka pata chala. So this is done. Okay. Similarly, left border. This left border can also be moved. Right? This is the left side. So this is left ventricle. So these two things are clear. Next, some portion, small portion, only this much. A small portion of left atrium, because left atrium is behind. Right? So वो पूरा नहीं दिखता. But this small portion, it gives the shadow slightly. So that is the left atrium. As such, so you can say that it is this part. This part. Right? That is what we see on the sides. Okay. Next. We first finish the heart. From heart comes out the arch of aorta. So arch of aorta, remember, it comes out from the antemediastinum and it goes towards the posterior mediastinum, right? Anterior to posterior, right? So if you are watching from the side, so you can watch aise aage se piche. But when you are watching it from front, so it would be like a graceful turn, right? Like this. So that's the thing. So this is the arch of aorta, which goes like this. Right? But this part is anterior and this part is posterior. Right? That part is anterior and that part is posterior. So when it goes posterior, so this the top of the heart, right? That is by aortic arch. This top one. Then we must have drawn this image so many times. This is what? This is pulmonary trunk, right? This is pulmonary trunk, and the aorta, it goes like this. And then in the aorta, there are three major vessels. This would be the subclavian, right? This would be the brachiocephalic on the right side. This is left common carotid artery, and this is left subclavian artery, and then it divides. This particular thing we are talking about, this is the pulmonary trunk. Right? This is the pulmonary trunk and then the pulmonary artery, because from here then it will be going to the lungs. Correct? That's what we now see over here. Yes. This part. यहाँ से निकला. Right? This part we just cannot see because it is overlapped by the heart. But as it takes turn, this is the pulmonary trunk. This is the pulmonary trunk. Right? It is also called as the pulmonary conus. Conus. C-O-N-U-S. Right? C-O-N-U-S. It is also called as the pulmonary conus. Then this is the right atrium. The right atrium में who enters? ऊपर से superior vena cava, नीचे से inferior vena cava. Here it is the inferior vena cava. This only this much portion. इतना सा just. So even when you have to dissect it, Because how inferior vena cava enters, it pierces the diaphragm and straight away it enters into the right atrium. Bas, itni choti. Because this inferior vena cava is as such below, right? The hepatic veins, right? They will be landing into this inferior vena cava and then it enters into the right atrium. From top, there comes the superior vena cava. From top, this is the superior vena cava. No valve, straight away the blood drops into the right atrium. So that is the superior vena cava and the inferior vena cava. Obviously, this one, right? This one, yeah. This one is what? This one. You are smart enough, right? That's the clavicle. Clavicle gets attached to what? Clavicle gets attached to manubrium sterni, right? This is the clavicle. So that's why this entire thing, this one, right? This particular shape. Right? So that is the manubrium. Fine. So we have completed manubrium, superior vena cava, right atrium, inferior vena cava, pulmonary trunk, aortic arch, left atrium, left ventricle, diaphragm, yes, we know that. Diaphragm, we know this. Left costophrenic angle, we know it very well. Diaphragm is known, right? This is the area where there is liver. So even that part is good because there is no air. If you find any air over here, that means something is wrong. And then see the shape. This is what? This is our stomach, and that's why this is gastric bowel, the air, right? And this is called as the air fluid level. It's called as air fluid level. This one. So it is not written over there, but it's called air fluid level. Right? So far, the heart part done. What about rest? That thing you already know. The right side of the heart, say this is what? All-time favorite, right? The horizontal fissure. Whenever there is consolidation of upper lobe, we find that this horizontal fissure is clearly seen. Right? So that was the thing. Over here, this one is the oblique fissure. It means which lobe is this? This is the middle lobe. So whenever there is middle lobe consolidation, what would happen? Middle lobe consolidation, what would happen? How will you detect middle lobe consolidation? Which is one sign. Dekha and you know it. No one? Oh. Yes. Airspace, कौन सी airspace? Which airspace? नहीं. Now, अब सब चार्ट. Heart border. So heart border means heart border is blurred, right? The border of right atrium is blurred. That's right. That is all. These are the concepts. This heart border that would be blurred. Why it has to blur? Because now there is no air. If there is no air, so that becomes like a soft tissue. So that soft tissue and the density of the heart, they become same, right? So X-rays, equal amount of X-rays will be passing. So we won't be able to see the cut of the heart, that shape of the heart, which is called as the silhouette. It is called as silhouette. Right? Silhouette, पता है? Sometimes when there is sunrise from the back, कई बार अपने photo लेते हैं, right? So then the photo it is like मतलब पूरा मुंह कैसा आता है, भूत जैसा, right? काला काला, right? And बस this is the time. No eyes, कुछ नहीं दिखता, right? Because it is silhouette. It is only the border which is seen because of negative lighting. So over here, this is classically what is called as a silhouette. Silhouette also is the outline. So we won't be able to see, we won't be able to appreciate the right side of the heart. Right? So here this is the oblique fissure. Similarly, in case of left side also there is oblique fissure. So that is the oblique fissure. In case of left, there is no horizontal fissure. On left side, technically speaking, there is just the upper lobe and the lower lobe. Right? And that is the right main bronchus, right? All these, and then it gets divided, and you are watching the BVMs, bronchovascular markers, So right main bronchus, and over here, this is the left main bronchus. Right. So thus you have identified almost every structure in this. Correct. This is a completely normal X-ray. Right. Initially, I'll be showing you normal X-rays only, so diagnosis ज़्यादा नहीं है. When it will come, I'll tell you. तो अभी diagnosis करने की try भी मत करो. First time we are now watching the lateral view. Lateral view, when it is said करे बहुत complicated. No, not really. Right? Lateral view is like mathematics. You watch it properly, 1, 2, 3, 4 steps, and you will find that you have identified it. So here is, in lateral view, these are the 3 very important findings. These findings, if not present, that means there is something wrong. So the moment you see, आँख वहीं पे जानी चाहिए. The first thing, what is called as the retrosternal lucency. Whenever you use the word lucency, means blackness, right? Where we say radiolucency, that means blackness. Radio opacity, that means white. When things are opaque, opaque means X-rays cannot pass, so it will be giving you white shadow. When it is radiolucent, radiolucent means X-rays, full-fledged X-rays they have gone, so it is blackness. So first thing, in this, can you see the spine? Right, here is the spine, right, bade aaram se. So that means this is the posterior and this one will be the anterior. Because we have identified this. If this is anterior, so then which bone this will be? This will be the sternum, right? Sternum. So over here, this is the dot, and I'm writing 1. There is a blackness, right? Can you see this? There is a blackness which is just behind the sternum. Correct? That's why it is called as the retro. Retro means behind, sternal blackness. Blackness behind the sternum. Retrosternal lucency. This is first. So this is first. Second, retrocardiac lucency. Now you are intelligent. Now in second you will say that, okay, this is the heart. Correct. You are 100% right. See the heart, how anteriorly is it situated. Right? So that is the reason कि जब अपने यहाँ से X-ray लेंगे, and if the X-ray plate is over here, so in AP view, see the distance. Obviously, the heart will get enlarged. Okay, so that's the heart. Now we have seen the heart. This is the heart. Our next lucency is this one. Retrocardia. Can you see the blackness over here? Right? Blackness. So this is the second one. You should, these are normal, huh? There is nothing normal, these are normal. You need to see these lucency the moment you see the lateral axial chest. So this is the retrocardiac. So this was 1, this is 2, so this is all. The third requires a bit of attention. Along the vertebral column, from top to bottom, right? You have to move your eyes from top to bottom. The lucency must increase. Blackness should keep on increasing. See that. Just focus only on this much. Here it is white, pretty white, and now it is getting dark. Here it is dark. All right. Technically speaking, this is this one. That's the third. As you go from top to bottom, along the vertebral column, lucency must increase. That means blackness must increase. Yeah. So these are the 3 important points. Again, USMLE question. I mean, today, because from this you will be getting the idea that what type of questions they ask. Right? So see, as such, they are very simple. But when it is asked, if you know it, it is easy. If you don't know it, it becomes difficult. See, once again over here, now everything is easy. You know everything about it. See, right humerus, left humerus, right? Then this is the blackness which you see, that is the trachea. Don't worry about the aortic arms, etc. Right? This is anterior, this is manubrium, sternum, this is right ventricle. See, right ventricle, right? Now we are right. Right ventricle is anteriorly situated. So that's why right ventricle is anterior. That's important. Gastric bubble, yes, see. These are the right costophrenic angle, left costophrenic. We are seeing inferior vena cava just at the base it enters. Then atrium, see left atrium is behind. So this is left atrium, this is right ventricle, right? And that's the left ventricle, which is seen slightly on the back side, and the right scapula. Lucency means blackness. Lucency means blackness. How much black? When you say opaque, so that thing would appear white. Right? Opaque means कि जिसके अंदर से light pass now. Right? So that is called as opaque. Over here we are talking about X-rays. That's why it is called as the radio. Okay? So light cannot, X-rays cannot pass through this. So that's why it is called as the radio opaque. Why is the vena cava shown in black? Which vena cava is shown in black? This one? This one you are talking about? Okay. Over here, what actually really happens is, this is the area. You know, this shadow, it has not been marked, but this shadow. Whose shadow is this? This is the shadow of aorta. That's why it is black. Right? Because over here, there is not much of the tissue. So this is the shadow. When it is amongst that blackness, right? This clear outline is going down. Right? It's clearly going down. So this is in posterior mediastinum, just near the spine. When we'll be discussing the CT scan, you'll see that this is the vertebra, and this is where you will see the aorta. See the aorta. So that is the aorta, which is, this is the aorta. Aortic impression. Why is this chair? Is voice okay? Is it? How is it okay? Oh, so, right? So that is opaque and the lucency. Lucency means blackness. So we have got now 3 lucencies. One, the retrosternal behind the sternum, retrocardiac behind the heart, and the increase in lucency as we go from top to bottom. Great. Next, this is the lateral decubitus. From this point onwards, things are now extremely easy. All the difficult portion is done. Lateral decubitus. Decubitus means जब side में ऐसे होके सो, that is what is called as the decubitus position. This. Now it is not so this when my teacher asked why this has been tied, मैंने कहा patient भाग ना जाए ना इसी वैसा. So, but that is not the reason. We need to make the patient immobile. That patient hilna dulna nahi chahiye. So, and see over here. Can you see this cross here? See. Actually, zoom. Can you see the cross here? See this. That is the cross. This is what it is called. So from here, this is the X-ray machine, right? Over there, on this is not seen over here. That's the tube, right? The light, it switch on the light, and then you cross here. And this one, this is the X-ray. This one is the X-ray. Looks like window. That's exactly. Right? So this is for centering. So in female patients, how it is done, right? You can easily palpate. Right? You can palpate that this is the inferior border. This is the inferior border of scapula and the mark. This is the centering and the X-ray. Now, why the X-ray? Because when you take this X-ray, it will look like a normal X-ray. But this is called as the decubitus. This is one of the best X-ray for diagnosis of minimal pleural effusion. When the pleural effusion, when there is so much of less fluid, right? Minimal pleural effusion, this is the best view to watch. Right? Investigation, this is IX means investigation. Investigation of choice. Investigation of choice is obviously USG ultrasonography. And you just put the probe, immediately you'll be able to see the fluid connection. Right? I'll show you the ultrasound also when we'll be discussing ultrasound, but before that we'll be discussing the principles behind the ultrasound. So this is where the pleural effusion occurs. See the pleural effusion which is occurring between two layers, right? Between these two layers. Visceral layer and the parietal layer of when the fluid gets collected, that is called as pleural effusion. In this position, it is seen very clearly. See this. Over here, this is the area. This is the area, right? You can actually watch over here. But this is not very clear. Now you can see it. Now actually it is seen. Actually it is seen. The fluid which is seen. But still, this I'll show you much better X-rays. But just remember that this is for the detection of. These are now posterior oblique for same-sided rib fracture. Posterior oblique. The right ventricle posterior view. Right ventricle. Ekdam simple. Na? Draw it like this. This is right atrium. This is right ventricle. This is right atrium. This is left atrium. This is left ventricle. This is anterior. When you are taking the X-ray from side, right? You are taking the X-ray from side, you will be able to see anteriorly. So here it is, right? Here are anterior. That is anterior. So that anterior border, that would be of right ventricle. Okay. Right ventricle. And this is the left ventricle. As such, big portion is by left atrium, but only the small portion of left ventricle it comes in the posterior side. But as such, this left ventricle is on the left side. It's on the left side. Am I clear? So here it is now posterior oblique view from same-sided rib fracture. Let's say my rib is fractured. If this rib is fractured, so what I have to do, I have to keep the fractured area near to the plate so that even if there is a hairline fracture, it can be seen here. Same thing, right? Posterior oblique view for same-sided fracture. Jahan pe bhi fracture hai, that side should be near to the X-ray plate. Right? So this part is solved. Anterior oblique. anterior, right? Anterior oblique view means what? You make an angle, right? This way or that way. So here you are adjusting, and with the digital access, it will become much easier. So right anterior oblique RAO for evaluation of sternum, esophagus in barium swallow. So when you are taking the barium swallow, you tell the patient that drink the barium. Patient drinks, गंदा सा मुंह बना के, right? दिल में गालियां दे के, right? He will drink it, right? Because it is of very bad taste. Though they say, मतलब बड़ा fine लिखा होता है, orange flavor, pineapple flavor. मतलब seriously उसकी, there is no orange flavor, there is no pineapple. It is that गंदा सा taste. We really मतलब tell the patient के शाबाश यार, खुद पियो तब पता चलता है. मैंने पिया था एक बार, just to know that patient को कहता है चल पी जा, एंड बेचारा पेशेंट यस यस करके पी जाए. मैंने कहा पता तो चले कैसा है. मैंने डिपार्टमेंट में पूछा सकते किसी ने पिया, कहता है नहीं. मैंने कहा लाद पीते हैं. आई मीन सीरियसली, मतलब कितना मस्त लिखा होता है ऑरेंज फ्लेवर. मतलब दूर दूर किसी जन्म में वो ऑरेंज नहीं. बेरियम इज दैट मटेरियल. बेरियम इज लिक्विड ही आता है. हाँ बेरियम पी जाने. Barium, it goes into the stomach, it goes into the intestines, and then it is flushed out. नहीं वॉमिट नहीं करना, वॉमिट नहीं करना. तो डिपार्टमेंट कैसे चलाओ? बिल्कुल वॉमिट नहीं करना. पेशेंट को गुस्से से बोलना पड़ता है चल उतर जा, because it is so bad. अभी भी मतलब वो इसलिए कि when you want to examine the esophagus, when you want to examine the stomach, when you want to examine the duodenum, when you want to examine the jejunum, you want to examine the ileum, right? You want to examine this large colon, right? So it tastes ganda, right? There cannot be any other word. English में word नहीं मुझे पता, right? It is ganda. चूने का पानी पी रहे हो ना, you know? It is like that. वो चूना बनाते हैं ना तो दीवारों पे पेंट करते हैं. What is that smell? Literally, it is like that. दो फ्लेवर में आता है, ऑरेंज एंड पाइनएप्पल. एंडोस्कोपी तो दोस्त, एंडोस्कोपी तो it requires हाँ प्लास्टर पुट्टी. Exactly, it is like प्लास्टर पुट्टी. सही, प्लास्टर पुट्टी उसके जैसा. एंडोस्कोपी कहाँ तक करो? Let's say someone has got the problem in the lower intestine. वहाँ तक एंडोस्कोप कहाँ जाए? Right? And even if it goes, it is damn costly. And it requires procedure. To put the endoscope, right, we used to do about 60, it is called as barium swallow. 60 barium swallow. Line se thaka, right, calm patient, right, chal pee jao, right, and technician is preparing, वो jug भर भर के barium बना. This was the load. Monday to Friday, धड़ाधड़, right? एक के बाद 400 X-rays we used to diagnose. So barium, what does barium do? Barium, when it goes into the stomach, so you are into the room. This is how the thing is, right? You are onto the machine, right? And then you tell the patient कि चलो पियो, right? Patient is on the other side, and then that is a fluorescent screen. So you can see that barium as it is passing through the esophagus, लगा esophagus में कुछ, press the button, right? अंदर X-ray ले लिया, right? Then the second, then the third, right? And then those plates they keep on developing. Then we say चलो side में हो जाओ. Barium swallow is especially very useful when you are diagnosing the epiglottis, right? When there is any problem in the epiglottis, you can see the pyriform fossa and everything. You'll see this thing in head and neck, right? That how those complicated structures, but they are those delicate structures, and those delicate structures they can be seen crystal clear, and they will be outlined. If the barium is made very proper, right? There is a method also to make the barium. If it is made very proper, it will line the whole thing so beautifully. You'll be able to see even the ulcers they are seen very nicely. And then there is a compression also. Right? That is like patient को लगे क्या बस he has reached to the Hitler Nazi camp, right? Because usko सुला के then there is a cone which is applied, and then सांस बंद, right? उससे होके पेट ढीला छोड़ो, अरे बेचारा यार, and then you press it, and then because the barium would be displaced, so wherever there is ulcer, right? That ulcer would be filled up with the barium and then you take the X-ray. And then department में वाह 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 क्या बढ़िया एक्सरे लिया है जानी तुमने, right? And वो patient गालियां दे रहा है कि साला इतना दुखाया, but it happens. That is life. It's fun. फिर पेशेंट को बोलना पड़ता है, देखो थोड़ा सा दर्द हुआ पर डायग्नोस हो गया ना, हाँ साहब, हाँ साहब. Because the reason is you need to compress. If you don't tell the patient to relax your abdomen, your patient will be feeling so much of pain because abdominal muscles, if they are not relaxed, right, and you are giving pressure. So that's why बड़े प्यार से पेशेंट को किसी को डांट के, किसी को समझा के, चलो भाई ढीला छोड़ो, पेट ढीला छोड़ो, bend the knees, लंबी सांस. And so when they take deep breath, the diaphragm will go up, abdomen relaxed, and it is bus with the, you watch the breathe and then you apply the pressure. Okay, हो गया, and take the exhale. So after 11 to 1, that was the section when you have to go for these barium procedures. Barium swallow, swallow is in the morning, barium meal, barium enema, all these things. Knees are bent because when the knees are bent, abdomen would be relaxed. Abdomen would be relaxed. So when the abdomen is relaxed, so rectus abdominis, that would be of a normal size. And then when you tell the patient take deep breath, so it will be still more relaxed, diaphragm will go, right, and then the abdominal contents. Then you take that. So right anterior oblique view. So from right or left, you change the angle of the tube depending upon when you want to evaluate the sternum or esophagus in barium swallow, right? Left anterior oblique view when you want to evaluate aorta or aortic window. This we do when you are going for angiography. When you are doing the angiography, so in angiography you don't tell the patient, because in angiography the patient is lying, but the table controls. They are like, you can tilt the page, this table. So when you tilt the table, right, the tube is over there onto the top, right? Tube is over there into the top. But because now the patient is lying this, you are tilted the table. Tube is fixed, and then you take the X-ray. So for patient to your oblique view, right? You don't have to like this and you tilt the tube and then you take. This thing can also be done. This thing can also be done. Both the things are possible. Right? You have got the controls for table as well as the top tube. Both the controls are there. This is right anterior oblique, left anterior oblique. Same thing what I said. Then there is one thing which is called as the lordotic. This is the view when you lower the, you lower the X-ray tube and then niche se shoot kar, right? You are taking it like this. This is especially when you find that the apex, right? Especially when this area, right? See, over here the apex is overlapped by the clavicle. So you can't see the apex very properly. So in such case, you lower the thing and then you take the X-ray, so you'll find that the entire apical lobe is seen clearly, because obviously the clavicle upar chalega, right? So you can see this more clearly. So classically for the diagnosis of middle lobe pathology and the apex, apicogram for the apex of the lung. So middle lobe and apex, both terms are used interchangeably. So lordotic view or apicogram, one and the same thing. Right? So that's what, so this is the journey to great diagnosis has started. So hang on, more and more things will be coming. So that's it for this session. I'm saving this file. See, I'll just put it into our folder. Seventh one क्या? Seventh क्या था? हाँ, I'll upload it. I'll upload it within 2-3 minutes. This one, this is the lordotic. chordatically means you are putting it an angle. See, clavicles are here. So जब आपने यहाँ से X-ray लिया, तो X-ray has passed just below the clavicle. So that's why these are the lungs. So you can see those lungs proper. That's why it is called as a picogram. See over here, this is the whole lung, right? Overlapped. This is the whole lung. See, clavicle ऊपर चला, है ना? Please share the drive link for PDF of lecture. Lokesh, if you don't have the link, just send a mail to me at this email address. Still you are mbbs@gmail.com, right? I'll send you the link. Revision batch. Revision तो अभी नहीं. We'll first let's finish. मैंने बोला ना, we'll finish the respiratory system. उसके बाद take the revision. ठीक है? हाँ, USMLE वगैरह सब उसके बाद. पहले now next time we'll be taking बस 2-3 sessions are left. So after that we'll be starting cardiology. I'll tell you about myself. I'll in fact show you many of the pictures. All right. So thank you so much. It's always a pleasure talking to all of you. Thank you. Bye-bye. Yeah, don't get the problem. Rita wanted to ask, you raised your hand, wanted to ask something? If you are there, you can unmute and ask. Okay. So here, see you next time.